Welcome everyone. So glad you could be here today for the presentation. We know you're taking time out of your busy day, so we'll get to it. So my name's Jeanette Kojane. I'm the Executive Director of Kokua Mauʻ. I know many of you, but there are some new folks on the line that I don't know. But anyway, wonderful to see everybody, and we hope this is the beginning of more conversations around the very important topic of messaging and around palliative care. So today I'm joined by Anita Jewell, Leslie Milligan, and the famous Hope Young from Kokua Mauʻ. We have, you'll be hearing from all of us. So today what we want to do is tell you about some of the fabulous work of our Palliative Care Awareness Committee, who's been meeting over the last 3 years. We want to present some of the possible messaging and stories that we've been working on developing, both for the public and for providers, to talk about palliative care, and then hopefully get some support for testing and expanding these messages. So what we really hope for today as the outcomes is that we can all agree to work on developing similar messages to help reduce confusion, because there is a lot of confusion out there. We really hope that you will use the materials, give us feedback, help us make them stronger. We very much would like to hear more stories, and we are interested in short testimonials. The last time we talked to a group, they were like, oh, let's have some short stories. So asking everybody to help us out. Several people may not know who Kokua Mauʻ is, but we like to say that we are leading a movement to make the conversations like we're going to have today more of the cultural norm. We want open and honest conversation about advanced care planning and serious illness to be happening in our community. And we are so glad that all of you are part of our movement. Kokua Mauʻ is a not-for-profit 501c3, and we have been going since 1999. And I know some of you have been involved for almost that whole time, and other people joined last week. So we love it that new people come all the time. We are a membership organization, and just eyeballing who's here, most of your organizations are members, and that is how our unique hui continues to exist. We also have amazing volunteers, some of whom are part of our committee and are on the line today, which again, how do we as a community make these conversations the norm? We like to start early, getting people talking about advanced care planning. Post, that is our kuleana. Post lives on the Kokua Mauʻ website. And then we want people to understand what palliative care is, what hospice care is, get other grief and bereavement resources. So we try and have the range of resources. And just a last slide about Kokua Mauʻ. We like to put people who may be facing serious illness and their loved ones at the middle of our work. How do we help people get good information? How do we help them find resources? So again, through the website, through the newsletter, and now through activities like what we're talking about today, how do we help people understand about palliative care as an example? We like to work with professionals. How do we help you do your job better? And then we work to change the system, whether it's through policy or legislation. And thanks to everybody who helped with our successful legislation this year to get POLST changes. So I'd love it if everybody in the chat could put in 1 or 2 words when you hear the word palliative care, what comes to mind? So no sleeping over your lunch hour. Put down your chopsticks. What is it that you think of when you hear palliative care? Just put them right into the chat and share with us. Great. Comfort, confusion. Thank you. Honesty from James. Being comfortable. I love it. The kind of care we all want. Ooh, let's steal that one. Patient-centered, serious illness, pain and symptom management. Great. We, in our presentations, always ask that question to get people talking, and we get a variety of answers. This is a unique group, but these are some of the things that come up: respect, comfort, partnership, which is also why for us, palliative care represents such an awesome and amazing opportunity. So So we are very clear that there is a lot of confusion, as James said. There's a lot of confusion out there, different understandings of what palliative care is, and depending upon who it is, people understand it differently. So I think it's important, and our committee, we keep remembering that that is the case. Back in 2021, there was a pandemic, but yet we continue to have palliative care conferences. And there was a group of people who said they wanted to work on the issue of palliative care messaging, marketing, awareness. So we formed a committee, and these are the people that have been there for a very long time. And I'm also very happy that new people have joined, like Kaylee E. Gray from Navian and Ari Mae Stocker from HMSA. Shout out to these folks who have been with us for quite a long time and done some of the fabulous work, very strong work that you'll see today. When we started, I will tell on myself, I thought this wasn't going to be that hard, and I was very wrong. It's important to say that in Hawaii, and nationally, there are a range of definition and criteria of what it is at palliative care. We know supportive care, concurrent care, integrated care, and palliative care. CMS has a different definition from WHO and CAPC. So in a relatively short period of time, it was very clear that both the public and providers were very confused. So really the first task that we had was to try to figure out what is provided, where is palliative care. So we had a fabulous nursing student who did a survey, what is available where, and that is up on our website. You can see there's a button that says where to find palliative care in Hawaii. We also did some simple things with our website, things like changing our language to agencies providing palliative care instead of saying the hospices provide palliative care. Everyone is confusing hospice and palliative care. Okay, so let's call it out. The agencies providing palliative care. And yes, I had a sticky note above my desk for quite a while trying to remind myself to say that, which now becomes very normal. And what we also did was we separated hospice and palliative care whenever possible. So we would have a sentence describing palliative care and a new sentence describing hospice care. So as we go through today, you'll see some of the changes we've made. These are just some of these examples to get us helping with the confusion that exists.
Hi. We got a call that this house is on fire. How can we be helpful? Well, the house is on fire, but I'm worried if you go in there it might send the wrong message. Wait, what? I'm with the fire department. Yes, I know. I think you could be really helpful, but I think the family might be worried something is wrong if the fire department shows up at their house. But something is wrong. Their house is on fire. Do you think there's any way you could talk to them, but not use the word fire? What? I just think if the family hears the word fire, they might lose hope. But I am with the fire department and I am here to help this family with their fire. Right, totally. I think you could be really helpful, but I'm just not sure this family is in a place where they're ready to meet the fire department right now. Can we call you the water support team?
So hopefully other people have seen these videos too. When I first saw them, I started laughing, and that's always a good sign. So we hope that people will use these in order to help their colleagues, the professionals, to understand what palliative care is, what it is that we do. So the next person who I'm about to introduce is Anita Jewell. She's going to talk about some of the work that we've been doing around providers and provider messaging. So when we started, we thought we need to educate both providers and the public. So this is a theme that comes up. We need different groups to understand how great palliative care is. So we decided to start with providers, and Anita's going to talk next about the work that we did And this slide and the next ones represent some research that was done with Professor Susan Ngidinos from USC. Hope and I worked with her, folks from Huipohala and Papalokahi, to create a report about where we are with palliative care in Hawaii. We are just, in the next newsletter from Kokua, we're going to give you the link to that report. And part of that report were the results of some key informant interviews with providers as well as the public. So when we began we looked at some of that research. So we actually began our work, and then the research happened, and we were very happy to see we're all on the same page. So Anita, you want to take over?
Hi. Yes, thank you, Jeanette, and thank you everyone for joining us this afternoon. I saw these bullet points, these themes from those focus groups, and I was like, I could identify with every single one of them. Because working with our physicians at PMAG, it's Pacific Medical Administrative Group, and it's a group of over 750 physicians, and that includes PCPs, specialists, it's across the board. And when we started introducing palliative care to our group, I can identify with every single one of these bullet points. One, they do need a way to identify the appropriate patients. They didn't know who was appropriate. Which patient do I refer for palliative care? Then the referral process needs to be simple. It can't be discombobulated and complicated. It needs to be an easy referral process. And our physicians are busy. They do want the extra support, but they don't want to lose their patients. And there's that concern, especially with PM. You get paid based on the number of patients. There's some patient stealing going on, and also losing control of your patients as patient goes to palliative care, but you're not my patient anymore. So there's that misunderstanding. Many don't know what palliative care is. Sometimes they're thinking of hospice, they're thinking palliative medicine. And there's some clarification that needs to go there. And I'm still getting those kind of questions. And and I've seen many referrals that come through, and the referrals are essentially very late. A lot of those patients who get referred are already hospice eligible. That's what I'm seeing. And then, families are crucial in decision-making. And as a matter of fact, they don't want to hear the word hospice. And a couple of days ago, of a patient that we wanted to refer, but the daughter was adamant. She didn't want to hear the word hospice. The minute she heard the word hospice, she was shutting down. And so those are the kinds of barriers we run up against. Phrases which may work for providers: get extra support, help to avoid the emergency room and other hospitalizations, help with your complex patients. Could be the eyes and ears in the home. I think that's important. Support for the family and loved ones. Not a place, but a process. That one's important too. And you work alongside the physicians. It's not a replacement, but it's a team thing. So working alongside the physician. So as Jeanette mentioned earlier, we're looking at educating, spreading the word about palliative care to both the physicians and the public, the patients and caregivers. And so we decided on a two-pronged approach. One prong was for our professionals, the physicians and all the clinicians. And then the other prong was for the public, patients and caregivers. So started with the physicians, the providers. And we started with working on a toolkit that addressed those bullet points that we saw on that previous slide. A lot of this toolkit was designed to address those issues and to help with the messaging, referrals, and make things to simplify the whole process. The materials are posted on the Kokua website, and I do send my physicians there to check it out. The materials are, they're free to use. Please use them, and they can be modified. And we did share them with our a variety of different entities, healthcare agencies, MedQuest, clinical leads, different physician organizations, and different agencies providing palliative care, and then the health systems as well, physicians organizations. And the items are on the website, the Kokua website. The one that's by appointment only is because it's a workflow, and everybody has their own workflow, and it really needs to be tinkered on a case-by-case basis. And so the 4 items on the website, the Kokua website, is that one workflow by appointment. The booklet is the trifold brochure that was built, and it was kind of localized. We made it Hawaiiana. The assessment tool or screening tool, and that was modified from Hawaiʻi Care Choices. Thank you very much. And CAPC, and it was modified to fit more our physicians in the community. The 10 clinical triggers, that was borrowed from Care Compass Network, and that was slightly modified based on feedback from Dr. Toby Smith and other physicians. And then the FAQs. The FAQs are supportive care FAQs for physicians, for the clinicians. This is not for the general public. Like, these are questions that came from our physicians when we first introduced care, supportive care so many years ago. I got a bunch of questions, and I was surprised at how many of them were so basic, and I'm still getting those same questions today. So, and when I looked online for FAQs for professionals, I couldn't find it. So this was built based on the questions that I received from our physicians right here on Oahu. And then the workflow I talked about. This is the assessment tool or the screening tool that was borrowed from Hawaiʻi Care Choices. It looks very similar. There's some small modifications to make it more applicable for our physicians who are out in the community, our PCPs. And it does include the palliative performance scale, the ECOG. And then some of it's just some general conditions, basic disease processes. I like this tool because it's fairly simple. It's 1 page, and it was fairly thorough as far as figuring out who to refer and at what point to refer. And then for those who received the referral and this form, it was easy for them to figure out why that patient was being referred. On the other side is the 10 clinical triggers, and that came out of Care Compass Network. And again, it was modified slightly to make it more Hawaiiana, more applicable to our needs here. Some feedback from our physicians and Dr. Toby Smith at HMSA. And it's just general conditions, 10 general conditions that I tell my doctors that if a patient's sitting in front of them, they have any one of these 10 conditions, put them on your radar. This could be someone who's going to be eligible for palliative care soon. So just kind of put that under, put that at the back of your head and kind of keep that in mind next time you see that patient and start talking about it. This is that brochure I was talking about, the trifold, back and side. The FAQs in here came out of a handout, FAQs for the public from CAPC. The questions came out of CAPC, but the answers were modified to fit what's going on here in Hawaii with our insurance companies and all that. So that is relevant for now, for today. And then we included the list of all the hospice agencies statewide.
And actually what Anita meant to say was all the agencies which provide palliative care, right? Instead of the hospice agencies provide palliative care. We practice over and over again, and yet here we are 3 years later.
We still slip.
We still slip. So yes, exactly.
That's okay. It's a forgivable slip, I hope.
Totally, of course it is. But I know you well enough that I can.
Yeah.
You call me out too. It's good.
Thank you. And we saw one video about where the fire department, not the fire. By Dr. Jared Rubenstein. He is a palliative care physician, and there are a number of short and funny and catchy videos to help colleagues, professionals, and the lay public as well understand what palliative care is, help them understand why it's important to explore if you do have a patient with a serious illness, or if you or a loved one has a serious illness. And there are links to his website that's included in our Kokua website as well. And we have our web pages at the Kokua website, and I like how it separates the tabs. So remember I said there's 2-prong approach. One was for professionals, the physicians and the clinicians, and the other approach was for the lay public. So there's 2 different tabs because the information they're seeking could be very different. So there's 2 different tabs two different areas to access information depending on what you're looking for and who you are. So there's the side for professionals, the clinicians, and then the other side for the public. And I do send my physicians to this tab. So it's a whole row of nice purple buttons. The bottom one, palliative care for professionals. That's where I'll send my physicians if they have many questions about palliative care. And the top button is palliative care for patients and families. And that's where I would send the caregivers or the patients to go look. Thank you. And then what else is needed for our doctors? What can we say to help them refer to our seriously ill patients to palliative care sooner than later? To this day, I still get questions. Oh, does the patient need to be 6 months or less prognosis? No, the patient's alert, so they don't need palliative care. So, I mean, I get those kind of comments still. So what do you say to physicians to help them to facilitate the referral of palliative care? If you have any hints or clues, please help me. I do bang my head against the wall several times a week because of this pressing issue. And if you would like to help us, let's test drive some messages. Is there anything that we already went through that would be helpful for you? And are you willing to help us? Thank you.
Well, thank you very much, Anita. That is great. And as you guys hear, what we want is communication, collaboration, working together. What we're sharing is what we've developed thus far, but we are in no means done. But this is, a work in progress. So we're going to shift now to the what kind of work we've been doing around reaching the public, and that is Hope Young. So take it away, Hope.
Well, thanks. So we actually have been doing a bunch of different ways of reaching the public. In 2021, we actually had a group of students from West Oahu reach out and ask if they could do their capstone project on palliative care. And so we actually had 3 students develop an Instagram campaign, and they were fabulous. They took it to a whole new level, and they were reaching out to a demographic that we hadn't tapped into. And so they did this whole campaign on what is palliative care, who would use it, who could benefit from it. They did all these various interviews. They did how could cancer patients benefit from it, how could COPD patients benefit from it, cystic fibrosis, pediatrics, congestive heart failure. They went into all the various illnesses, and they touched on it and how could palliative care services benefit patients and their loved ones while they're dealing with serious illness. They also did interviews. So they took time and they did a weekly live on their Instagram channel, and they had interviews with Dr. Fishberg. Jeanette and I were both on that. They also talked to Andrea Bacos, who was a caregiver as well as a spouse who her husband had palliative care the last few years of his life. They talked with Sarah May Colon about spiritual care and palliative care and how those work together. They promoted information from CAPC and Get Palliative Care. They did such amazing work in a span of about 3 months. It's really amazing the things that they did. So we invite you to go and take a look at it. We have continued to use what they started on, and we use that for all our Kokua web posts on there. But really what they've put up on there has been amazing. So continue to work with us in various capacities, whether it's volunteering or just in and hanging out. So we really appreciate the work that those interns had done when they were in school, and now they are colleagues. And so another toolkit that we had used, and we do like using things that people have developed, and we like to cockroach them and steal this message as they have asked us to do so. Dr. Tony Bach and Marianne Grant had created this project. It's the Serious Illness Messaging Toolkit. And they had heard about the work that our committee had been doing, and they asked to come and talk story with us. And so we had the opportunity to talk story and pick their brain and kind of talk to them about what's going on here in Hawaii, because we really like their principles, but we realized that the messages just weren't working for us here in Hawaii. And so we wanted to kind of figure out with them, wordsmith with them, and figure out how we could make better messages that would work here in Hawaii. So their principles, very simple. Talk up the benefits, present choices at every step, use stories, invite dialogue, and invoke a new team, because most people don't realize that there is a team involved that can support them and their loved ones through their serious illness journey. So these 5 messaging principles, we took those and we started talking with people in our networks, in our various networks, and we started asking about different messages that we're trying to develop to see how well we could take local messaging and make it better for us here in Hawaii. And so we recognize that these are some of the things, the takeaways that we found out from our talk story sessions out in the communities. People like a 24/7 approach, that there's 24/7 support out there when you're getting palliative care services. They like that there's a team approach. They prefer the home over the hospital, so that really resonates with them. They really appreciate the idea that there's support for their ohana. They don't necessarily think of their loved ones as caregivers, but they do recognize that having that support for their loved ones really makes a difference. They like the fact that you're building these relationships, not just with their loved ones, but with their providers. And there's this idea of malama for the kupuna, respect and taking care of their elderly. Knowing that it's not just for the elderly and it's also for anyone with a serious illness, that we're also recognizing that you don't have to give up anything by including palliative care, that you're actually getting more by including palliative care. Knowing that you can still get curative and disease-modifying treatments, knowing that you can still get treatments to make you get better, that helps. And knowing that communication can be improved between your loved ones and your doctors through palliative care services. These are all things that people resonated and thought these are really good ideas and good themes that people gravitated towards. Things that we thought would work and things that some feedback that we got on things that we thought would work. We talked to some community health workers and we asked them, what do you think about an extra layer of support? And they said, ooh, that sounds like more paperwork. Why don't you just say extra support? Oh, okay. And then we asked people, what do you think about quality of life versus help you to live well with serious illness? And people kind of, they scrunched their nose up and they said, we don't like quality of life. Okay, so we like helps you to live well with an illness. What about helps you to live well as long as possible, or as long as, and they like that. They liked walking alongside and being an advocate for you. Again, we're wordsmith messaging. The things that we learned from these conversations out there in our information fact-finding conversations, people don't like statistics. They don't want to know numbers. They don't want to know how it can help someone else. They want to know how it can help themselves and their loved ones. Palliative care can help your doctors talk together. The response was, what? Aren't they talking now? We know here in Hawaii, autonomy is not important as much as family and ohana. So we realize that folks will do this for their loved ones. They will initiate questioning about palliative care services because it supports their loved ones and not necessarily for themselves. We recognize that at any stage of a serious illness, we are here to help. It's not really as good of a messaging here because here in Hawaii, we know that insurance doesn't necessarily cover palliative care services, not yet at least, or they don't necessarily qualify for the services that their insurance may cover. So that phrase doesn't necessarily work for people here. And then that terminology, get the best medical care, it could actually sound like you're not getting the best care possible right now. So we want to remind people not to promise too much when we're talking about palliative care, because it is something that, while it's the best possible care possible for people with serious illness, it's not quite as readily available for folks as of yet. This video, we actually talked to Andrea Bacos, which is someone I mentioned earlier, our interns. They did a video with her. Well, they posted the video about her. But this was an opportunity to talk with somebody who actually had been involved with her husband's journey, her husband's cancer journey. And she talked openly and freely, and she gave her testimony about how well pain and palliative care works for her and her journey with her husband. And it actually encouraged her to become a community health worker working in the cancer field. So we invite you to go and take a look at our YouTube channel. And she has two different versions of this video, an edited one for 3 minutes and a longer one for 15 minutes. By all means, we invite you to go and take a look at it. Leslie.
Yes, hi everyone. Thank you for joining. So I'm going to talk about being aware or beware of assumptions. So when we're out in the community, talking to patients and their families, we see that, having a serious illness, it changes, their perspective, their values. So we need to really read our patients, their families, and using an approach that works best for them who don't have the experiences that we have. So we really, avoid a lot of that clinical jargon and really listen to what their needs are. So we did define that as being very important. They're not interested in death positive talk per se. And, when we're talking about palliative care, most of them, they don't really want to think about hospice. And we wanted to really define that palliative care is not hospice. And for some of our hospice agencies that offer palliative care, hospices in our name, we're one of them. So, clearly that's something that when I'm talking to patients and families in the field, that's something that I kind of clarify in the very beginning, just because it's in our name. So I have to kind of address it. People, also have not had positive experiences with medical care for serious illness. So it's really, explaining the difference and how we're there, to support with palliative care. This is something that was shared to us by the wonderful Dr. Fishberg. And I know it's probably tiny on your screen. So I feel like it's so great to define palliative care to the public. So like we are the fire department, not the fire video is really good. A good visual for providers. I feel like this is a great visual for patients and families. So
Can you read it for us, Leslie?
Yes, I'm going to read it. So first, as you see, there's a couple, or I assume 2 people sitting there talking to the provider. And then the next one there, it says a few months later, they're in the rain. Next one, the doctor's running out to them with an umbrella. And it says, "Here, this will help," says the doctor. And the woman says, "Thanks. Wish we had this earlier." Okay, so that's late palliative care referral. That's what that's supposed to represent. The next one, the next strip is supposed to represent early palliative care referral. So same first slide. And then it says, "Here," says the doctor, "you may need this. You may not need this yet, but just in case." And then a few months later, it's pouring rain. They open their umbrella. They have it. I also like how they show the other person without the umbrella, just a newspaper over their head. And then it says, "So glad we had this when we needed it." And so next slide, we'll talk about the umbrella. The umbrella metaphor, just palliative care is the umbrella, not the rain. Predicting the rain can be difficult. Having an umbrella will not bring on the rain. And in the field, I see this a lot where they're just like, for the most part, when I do talk about our palliative program to patients and their families, they're relieved. They're so thankful for this extra support. But there are times that I do talk to patients and families and they're like, "No, you know what? We don't need it. We're good. Like, we have our doctors. We're good. We don't need this." But we know that they need this, right? They just don't know. And then the very next week or the next hospitalization, they're like, "Gosh, you know what? We should have listened. We should have had that, sooner." Or there's also patients that we meet. They're like, "Oh, I wish I knew about this a year ago when I was going through my treatment and things are really bad." So again, I love this, the metaphor of the umbrella. So issues with messaging, being mindful of the visuals that we put out there. Like it did say, research has shown that, not using hands, not using butterflies, but really using photos of people in a positive setting, a realistic setting, something that is meaningful, something that connects with our local community. So again, not overly joyous faces, no rainbows. That's what we found. Also, yes, so that's a good example. We decided that we were gonna have meaningful stories, and we came up with building stories that could show the benefits of palliative care. Palliative care gives extra support in your home, that helps you get home, a nice transition home, so that you can spend that time with family, less visits to the hospital, that there would be less stress and burden on the family, so that we are there to support not just the patient, but their family and their caregivers. That for palliative care, we would provide someone to call 24/7 if there's a problem. So I know that definitely lifts the burden for many patients and families, just to know that they have that safety net of that 24/7 triage. And then that we're helping to manage symptoms of the patient's illness, such as pain, symptoms and side effects to their possible treatment, explaining care and treatment options to the patient and loved ones, and referrals to other resources. So again, advocating for the patient, also us being an extension to the already in place care team. Those are the benefits of palliative care that we built these stories around. Yep, I'm going to turn it back. Yes.
So I'm not going to read this to you. I wanted to tell you the story, but these are available for you to print up and share. These slides are also going to be made available for you later on, so that you can download them and refer to them as you see fit. These stories we developed so that we could share stories about how palliative care can actually support people living with serious illness. So Tutu Malia is a 69-year-old kumuhula, and she had a heart attack 6 months ago. She developed heart failure. She wound up going back and forth to the ER and had a few hospital stays. She wound up staying in the hospital, but she'd much rather be at home. And so her doctor actually prescribed her, found her a program, a home-based palliative care program, where she had a nurse and social worker coming to visit her a couple of times a week. And she was so happy because her insurance actually paid for these visits, and she was supported in her home. It was no cost to her, and she had 24/7 phone support in her home. She actually got to the point where she was recovering. She had the support in her home, and she was feeling much better and supported in her home. She got so much better that she started feeling better and was able to be with her family and feel much better, more like herself, all because of the palliative care she was receiving in her home. Our next story is on Jasmine. Jasmine is a 48-year-old local woman with breast cancer receiving chemotherapy and radiation. She is a mother of 2 teenagers, and she had severe side effects. Her husband was actually not very comfortable with her cancer diagnosis. Her kids weren't dealing with it very well, but she was also having nausea and fatigue and feeling very overwhelmed because of everything that was happening within her own home. Her doctor referred her to a home-based palliative care program, and they started helping her with her side effects from the chemo and the radiation. And then her social worker came in and helped the teenagers, the son and the daughter, get into a support program for teens so that they could talk about what's going on with them. And then they also found a program for her husband so that he had more support and he was better supported in the home, which actually helped Jasmine feel not so overwhelmed by all the things that were going on around her. And she could actually concentrate on what was going on in her own cancer journey. As she started finding her ground, she started feeling a little bit better and finding her new normal. And now she feels like she can live with this current situation, all because of the things that she was getting, the support that she was getting through her palliative care services. This quote is from one of our Palliative Care Awareness Committee members when she actually was getting support for her husband before she was getting support for her husband. She felt like she was drowning so many doctors and so many medical terms that she didn't understand. But her palliative care team took the time to help me understand and find a way forward that works for me. These stories were intended to show how the palliative care team can really support people who are dealing with serious illness. And really, when folks recognize all the benefits that they can get through palliative care services, it really shifts the way that folks look at palliative care and look at how they can deal with serious illness and how they can thrive while they're living with serious illness in their own home and get better care and support where they're at. And so having someone to be able to call at 24/7, that really makes a difference than thinking that they always have to go to the emergency room. Having those symptoms, illness, pain, shortness of breath, having those managed can really change how somebody can live with a serious illness. Having those referrals and resources available because someone from the outside sees what they might need, that can really help support families and loved ones caring for someone with a serious illness. So we want to make sure that folks recognize that these are why we created those stories. But we want to know whatever stories and successes that you have that you could share with us. So we would love to hear how can you help? Let us know if you use these stories or if you have additional stories that you'd like to share with us so that we can use these stories and share them with others as well.
Okay,
Yeah.
well, thank you, everybody. So we are combining 3 years of work into a short presentation, and I'm sitting here thinking, oh, we need to have some more conversations, some breakout rooms, some other conversation. So if you're interested, let us know. So next slide, please. So there were a number of topics that come up all the time in palliative care, and I do want to say the first one is we are not going to rename palliative care. This is going to stay palliative care. So the next topic that comes up all the time is, do we mention hospice? So nationally, CAPC separates very much out hospice, never mention hospice, don't talk about hospice. But our group, and this comes up all the time, we find that really problematic because the palliative care is provided by agencies that also provide hospice. People transition from palliative care to hospice. A lot of people are eligible for hospice when they enroll in palliative care, like Anita was talking about, and Leslie. So if we're not telling them about it, it's almost like we're sort of lying to them. So, and we never want people to think that hospice is not the gold standard. So to quote Hope Young, love the phrase, palliative care is not the same as hospice. Let me explain the differences. Like, we need to be creative about how we talk about this. So another thing is that as we look at this, we need to remember there's different messages. So do you have 30 minutes? Do you have 12 minutes? Do you have 30 seconds? Are you doing a face-to-face in the hospital? Are you creating a poster for the door of the waiting room? Are you talking in the community? We need to be thinking about different messaging and different techniques depending upon what the situation is. Today, and the work that we've been doing, especially because of the exciting new Palliative Care Services Benefit, we would love that everybody works together to get the similar language so that we can help take care of some of this confusion. So if we can have one set of messages or a direction that we all agree to take, that will really be helpful. And I feel compelled to also say, we really hope with the new benefit that we can also have one intake form, one referral form, one billing, like let's have the reduction of paperwork. But this really helps. And we have this amazing, amazing opportunity moving ahead. And as we know, the Palliative Care Services Benefit is a preventative benefit. So we think that that's really interesting. Not only is it a game changer that we have this benefit that can be from the time of diagnosis, and that is going to be defined for the first time, but it's now preventative. Okay, so what does that mean? We need to think that changes things up. And the other interesting things that we've learned is that MedQuest needs to approve all the wording that the health plans put out about the new benefit. So if we can all be together, and I will say the health plans are really interested in all being on the same page, hey, maybe we can actually have some uniformity here. And that's what we're working on. Next slide, please. So the question is, what are some possible new benefits with this, or what messages for our new benefit? At any stage of a serious illness, we're here to help. Suddenly, we're not waiting as we've had to do until the very end. We can start earlier. As a public health person, I always think of palliative care and the work we do as prevention, preventing crisis, suffering, family stress and burnout, preventing unwanted hospitalizations. Other phrases that come up: access to your care team when you need advice, back to that 24/7 idea. Support for caregivers. We can talk about the ohana, that is part of the benefit. So it's very exciting that this is happening, and you're all welcome. We are all in this together to make this work. Okay, there's just one or two more slides. I want to make sure that people know we've put a bunch of great resources up on our website to help with serious illness conversations. CAPC has good resources, the Serious Illness Conversation Guide from Ariadne Labs that so many people used during the pandemic. Vital Talk, hopefully folks are hearing more about Vital Talk. Hui Pohala is training a next round of cohorts to teach Vital Talk in the Vital Talk way, and Beth Freitas, who's on the call, is the best person to ask about that. And there are 2 local videos that explain more about the Vital Talk method. So go to our website and look. The Conversation Project is there. We're super users of Conversation Project. And then Go Wish cards. I would buy everybody in our field Go Wish cards if we could. And then this morning we put in a link here to the videos that we showed, the Rubenstein video. So hopefully people can go and find the resources that we, and if you find other resources, let us know. Last slide. So we are hoping that people are interested in working with us. As Hope said, we are going to be gathering more stories, especially and to illustrate different aspects of palliative care. And we're really interested in short quotes about why palliative care was helpful. Those could be from just any kind of people, patients, families, loved ones, providers. We would love any sort of quotes that people could help us with to make it easier to understand what palliative care is. So I really appreciate everybody coming today, and I'm going to just check and see if anybody has any questions, put them into the chat. Otherwise, we hope that people will reach out to us and will say, yes, I'd like to be a part of this project moving forward. I sort of feel like it's, eating an elephant, that we have to take bite sizes or, we'll never consume the whole thing. So, and Chad has written extended acute length of stay, ER visits, 30-day readmission, hospital mortality. There we go. Yeah, and these are all, things for providers. Does the public know it? Maybe we can phrase it in a different way, keeping people out of the hospital. So again, within my brain, it's like, okay, what works for providers to get them over the hump to refer or to talk it up with their patient, and then they need good wording to get their patients to talk about that. Improve patient outcome, that's another good one. I think Leslie was talking about the being the eyes and ears of the doctors in the home. That's also really important as well. So. And then Chad had the interesting comment at the beginning there, or not the beginning, before. I find the concept of ohana being more important than autonomy very prevalent among multiple cultures here in Hawaii, and can complicate communication surrounding prognostic understanding and planning the patient's wish as the disease progresses. So thank you, Chad. Like, none of us are saying it's easy, but I love it that we can all be working together to strategize about how can we be talking about this, especially with this new benefit, because that is really, we have an amazing opportunity where we have a defined benefit and very robust moving forward. Rachel says improved patient satisfaction. Yes, we see that all the time. Families are really happy once they get palliative care. So those are all good comments. Okay. So I realize your lunch hours are coming to an end. Any last comments or ideas that people have? I hope that people will reach out to us and be part of the work moving forward. I'll ask my fellow presenters if they have any other last comments or things they'd like to share in the last 1 minute before the hour is up. Nobody's saying anything. So that's there we go. Anyway, so I totally appreciate people's participation and comments. As you can see, we have this amazing committee who has really done great work, and it is a privilege to work with them and also lots of fun. So, and then, in our field when we could say that things are going well. So I look forward to working with all of you. Thanks very much for coming. So there we go. So thank you very much.